it's my pleasure to introduce Dr. Joel Lexchin, who is a friend, a colleague, and a mentor. I started doing drug policy research in 1994, and I went to the Ministry of Health website in Ministry of Health library in Victoria, and I went to the librarian. I said, look, I don't know anything about the pharmaceutical industry. Is there anything that I can read? And she gave me this book. This book, which I'm holding in my hand right now, it's called The Real Pushers, A Critical Analysis of the Canadian Drug Industry, written by this guy, how he looked in about 1978. Joel Lexchin has been covering the issue of the relationship of the pharmaceutical industry and prescribing for more than 35 years. He's, without a doubt, Canada's preeminent expert in the area, probably the world's leading intellectual in this particular subject. It's a great pleasure to have Joel here. And there was a tweet this morning by a colleague in the U.S., Paul Thacker. He said in a tweet that Joel Lexchin is the world's expert on the corporate influence in medicine, and that influence is not abstract. It affects the medical care of you and your family, and Joel is also a very nice guy. So I agree with all those comments, and I'm going to hand it over to Joel to take over.
All right. Well,
actually,
thank you,
Joel, sorry to interrupt. Before you continue, it's Aaron to Jenny. We just want to ask people to check the chat, the audience polling system. Alan, can you explain to them the process? Yeah.
So please, any questions in the course of Joel's presentation, please put them in the chat. I'll be summarizing, and we'll be posing the questions to Joel at the end. We'll have about 35 or 40 minutes of presentation and maybe 30 minutes or so of questions. I want to remind everyone this will be recorded and put on the website of the TI. If you have to leave early because you have to tuck the kids into bed, that's fine. You can still get the rest of it. And the chat box also features a code if you want to vote in the poll. So Joel will have 4 questions in the course of his presentation, and you can go to the Slido, Slido.com website, enter the code, and you can vote on the questions. So carry on there, Joel.
All right. Thanks, Alan. I'll just pull up my screen. Just need to go back. By the way, I still look the same as on the cover of the book, or the back cover of the book. And I really am a nice guy. Okay, so this talk is about the relationship between physicians and the pharmaceutical industry. And as you'll see pretty quickly, I have my own biases about what this relationship is. You may not share that, and that's fine. I'm going to present what I think, and I hope we have a good discussion about this topic. So here is, since I'm going to talk a lot about conflicts, these are my conflicts. And I hope that people have had a chance to read them, because the average length of time that slides around conflicts are shown at least at conferences is 2 seconds. Barely enough time to see anything, and if you blink, you miss the entire thing. So at this point in time, at least, doctors are not showing their conflicts for long enough for anybody to really understand what they are. So I have 4 learning objectives for this. So the first one is look at the relationship between doctors and industry. One of the points that I hope you come away with is that I don't think that doctors are being bribed by the industry. I think that we're all pretty ethical people, and giving us money isn't going to directly change the way we think, but it will do it subconsciously, and I'll cover that in a few slides. I will also want to look at how the relationship will influence the treatment that patients get, and finally explore ways of reducing the influence of industry on how doctors practice. So with that in mind, I'd like to get started. And this is my view of the current relationship between the medical profession and the pharmaceutical industry. I'm not quite sure who is the medical profession and who is the industry in this slide, but as you can see, it's pretty close. And this is confirmed by a survey a few years ago by the Medical Post. They sent out a survey to 1,000 doctors and asked them a series of questions. So almost half of the doctors had some kind of a financial relationship with the drug company in the past. The vast majority did not have any problem with patients knowing about that relationship, and half of the doctors said that they wouldn't be able to do as much for their patients without that relationship. So people felt that that relationship was important, improved the way that they practice medicine, and were happy for people or their patients to know about that relationship. So the first question here is whether or not you have had a financial relationship with a drug company in the past 5 years.
Yeah, the vast majority, 80+% saying no.
All right, so clearly you people weren't the ones that were being surveyed by the Medical Post. So I'll move on. So this is a slide looking at what happens when doctors get their information directly from drug companies. So that might be in the form of talking to sales reps. It might be in going to CME that's sponsored by drug companies. It might be reading medical journal ads, any of those things. This was a systematic review that was done in late in the 2000s, and we found a total of 58 studies that we could analyze. And out of that 58, and we measured prescribing in 3 dimensions, so the cost of prescribing with the assumption that the more costly the prescriptions, the worse doctors were doing, the more frequent doctors were prescribing, the worse they were doing, and we also looked at quality. In other words, was the prescription that was written appropriate for the problem of the patients? And these were all based on, all these 3 things were based on what was found in the studies. And 45 of those looked at what happened when doctors saw sales reps. So some of these 45 found poor prescribing on 1 or more measures. Some found no change, and only 1 of the 45 found better prescribing on 1 measure. So the overall conclusion is if you see a sales rep, you're probably not going to improve your prescribing. It may not get any worse, but there's a good chance that it will. And the relation, as I said at the start, the relationship is not one of bribery. The relationship is based on gifts and what's termed the gift relationship. And what is that? Well, for those of you who used to go or went to the Los Angeles International Airport in the 80s and 90s, in the common area of the departure lounge, you would often see the Hare Krishnas walking through. These are people who were dressed in these colorful robes. They were banging tambourines and singing, and I won't attempt to sing what they were singing because my voice is awful. And when the Hare Krishnas approach people, the usual response is to try and run away. But if you don't see them soon enough and they actually manage to reach you, they will offer you a small gift of some sort. They may give you a flower. They may give you a pamphlet. Some people would take these things, even though when the Hare Krishnas left, they would throw them away. But if they took them, something that they didn't want from somebody that they didn't want to really associate with, a lot of people would give them money. And that is the gift relationship. This feeling that if you get something from somebody, you have to reciprocate. And another way of thinking about this is with the coming holiday season. If you get a Christmas or Hanukkah or another card from somebody that you didn't think was worthwhile giving one to this year, chances are that you'll give one to that person next year, even if your relationship with them hasn't changed, because they gave you something and you feel obligated to repay that gift. And that's been studied in a more formal manner. This is a paper that was published, an American study that was published a few years ago, and it looked at how doctors felt about taking gifts from drug companies, but under different conditions. So if you look at the bottom, that's the control, and you ask a conflict of interest question. So do you think that it's okay to be taken out for dinner by a drug company? And you get people answer that. You ask that question, and then you pose what are called sacrifice questions. Sacrifice questions are things like, remember, how many nights did you have to be on call before you could get into practice? In other words, how much time did you have to sacrifice? How many weekends were you stuck away in some hospital rather than outside walking around in the sunlight? And then there are the rationalization questions. And a rationalization question is, I work hard. I do a good job for my patients. Things like that. If you ask those things in that order, then 1 in 5 doctors think that it's okay to take gifts. You go to the top. You start with the sacrifice questions first. How many weekends did you lose? How much time did you not spend with your kids? Then you ask the conflict of interest questions. And finally, the rationalization questions. And if you do it in that order, almost 1 in 2 doctors think that taking gifts is acceptable. And if you go with sacrifice questions first, rationalization, and then you ask the conflict of interest, you get up to almost 2/3 of doctors who think that taking gifts are acceptable. So depending on how doctors think about gifts and whether or not they deserve them, a lot of doctors think that it's okay to take gifts. And so those of you who know about the Sunshine Act in the United States, this is where drug companies have to report anything of value, anything that's worth more than $10, meals, direct payment, anything like that that they've given to a doctor has to be reported, and you can look at how much money doctors have taken and combine that with the way that they've prescribed using the Medicare database in the United States, and you can link those two databases to see whether or not gifts make a difference in prescribing. And what these slides show is that a meal that is worth $20, so, you know, a little bit better than McDonald's, but not a lot better, a meal that's worth $20 will lead to a higher prescribing rate of a product that's being made by the company that's sponsoring the meal. So it doesn't have to be large amounts of money to change doctors' prescribing. And, you know, we're not bribed for $20, a $20 meal. We may not even like the meal, but that amount of money creates the gift relationship, and we reciprocate. So next question. Is it okay to take gifts of small value? And the other thing about gifts and relationships is that, by and large, there have been a number of studies that have looked at whether or not doctors think that they're going to be influenced by those gifts. And when you ask doctors about themselves as individuals, the answers you get are what you see on the left-hand side of your screen. So only 1% of doctors think that they, as individuals, will be influenced by having a relationship with the drug company. 61% say that they won't be influenced at all. But if you ask them about their colleagues, they're not quite as sure about their colleagues. Their colleagues may not be as ethical as they are. And if so, only 16% of doctors think that their colleagues won't be influenced. And a third of the doctors think that their colleagues will be influenced quite a lot. So we have this feeling of individual invulnerability. We're ethical, we're smart, we can see through what the drug companies are trying to do, but our colleagues may not be quite as ethical or quite as smart as we are. And this is from a study of internists and internal medicine residents in the U.S., and this kind of study has been repeated as at least 4 or 5 other times that I know of, with basically the same results. So one of the ways that doctors get influenced is by seeing the sales reps, the men and women who go around from office to office talking to doctors. And based on that same medical post survey that I started with initially, about 2/3 of doctors were seeing sales reps in 2015. And the graph here is a few years older than that, but about 1 in 6 doctors were seeing a sales rep a day, and at that point, a quarter weren't seeing sales reps at all or rarely saw them. So what do we know about sales reps and how they interact with doctors? So first of all, here's the amount of money that the drug companies spend in Canada on sales reps. So by 2016, the amount of money had dropped, but it was still quite a lot. $408 million were spent on doctors. So that's, there are about 75,000 of us. So that's a little under $60,000 per doctor per year just on sales reps. And then there's all the other kinds of promotion. And if you look at it, it's not quite as much as the companies were spending on research and development, but it was a fair proportion of that. Now, why do doctors see sales reps? Again, here, this is a bit old, but there were two main reasons for seeing them. One was the information that they get, and the second was the samples they get. So we don't have universal pharmacare. We know that there are lots of people out there who can't afford medications, so we take the samples to give to these people so that they're not going to leave the office without being able to get treatment. So the problem there is that samples are typically not the samples that are given out by the drug companies, and these are the newest drugs, which also tend to be the most expensive ones. Samples are often not the first-line choice of treatment. So a few years ago, there was a study done in the family medicine clinics in Quebec asking doctors how they used the samples that they would get, and half of the doctors who were giving out samples said that some of the time they would give them out even if the drug was not their first choice. So the availability of samples coupled with the perception that people might not be able to afford the medication means that we're not giving them what we think is the optimal treatment. What about the information that doctors get from the sales reps that they see? So this is from the Code of Ethical Practices of Innovative Medicines Canada. Innovative Medicines Canada is the lobby group for the large multinational drug companies, and things that are underlined in red: full and factual, no misrepresentation or exaggeration, accurate and complete, not be misleading, which sounds good, but not what happens in practice. So about 10 years ago, I was involved with a project that was led by Barbara Mincies, who at that time was at UBC. And what we did was we recruited general practitioners from 4 different cities: Montreal and Vancouver in Canada, Sacramento in the United States, and Toulouse in France. And we were interested in the kind of safety information that the sales reps were giving to doctors. So after the doctors saw the sales reps, they had a questionnaire form to fill out, and then we collected all these questionnaire forms and collated the answers and analyzed what was on them. And this is what we found. So we'll just look at the 2 Canadian sites. So did sales reps spontaneously mention non-serious adverse events? And that occurred in about between 1 in 5 and 1 in 4 visits. Contraindications, about 1 in 6 visits. Serious adverse events, 6%, so that's about 1 in 20 visits, and drug-drug interactions, 1 in 50 visits. So when it comes to harm, the sales reps are not giving doctors the information that they should have. So what do doctors think about these presentations that they heard, and did they think that based on what they'd been told by the sales reps that they were going to change their prescribing? So again, we'll just look at the top 2, Vancouver and Montreal. So despite not getting very much in the way of safety information, most of the doctors said that they were either somewhat likely or very likely to start prescribing if they hadn't already been prescribing the particular product, or that they were going to increase the number of prescriptions that they used, and in Montreal, basically the same thing. So despite not getting much information about safety, doctors still said that they were going to prescribe more, either start prescribing the drug or prescribe more of it. So, next question. I see sales reps because free samples for my patients. I'm friends with the sales rep. It's a nice break in the day. I get new information about drugs, or I don't see sales reps. Okay. So another way that doctors or drug companies influence doctors, or at least try to, is the use of what are called key opinion leaders. These are doctors who tend to be relatively well known, and they get hired by the companies to go to events and speak about companies' products or medical problems for which the companies make drugs. And a number of years ago, Purdue, the makers of OxyContin, were paying about 100 doctors, Canadian doctors, per year to speak on the company's behalf, and they were paying up to $2,000 per talk. And one of those doctors was Brian Goldman, who probably most people know as the host of CBC Radio's White Coat Black Art. And Brian is an emergency physician, so those of you who are emergency doctors know we see a lot of people with pain-related issues, and he got interested in trying to educate doctors in the best way of managing pain in the emergency department. And as he got known in this area, he got asked by companies to speak for them. And he wrote about this in one of his books that he's done. And so he would be flown business class in airplanes. He would be taken out to fancy restaurants by the companies. He would be put up in five-star hotels. Now, he's since recanted and says that this was a mistake, but these are people who are nominally supposed to be independent, and if you talk to them, which there's somebody at Queen's University who's actually studied this, these people will say that they're independent, they're not influenced by the drug companies, but that's not the view of the drug companies about them. Here you can see Kimberly Elliott was a sales rep who used to recruit these key opinion leaders, and when she was interviewed after she left the drug company, here's what her view of why the companies would employ these key opinion leaders. They would measure the return on investment. So in other words, how many prescriptions did the talk generate? And if the speaker wasn't getting the doctors to write enough prescriptions, they would just drop that speaker and try and look for somebody else. Medicine is getting more and more complicated, at least I find it that, or maybe I'm just getting old. But the literature says that doctors are moving to use clinical practice guidelines more and more to help us guide the treatment that we give, or the way that we diagnose people and the treatment that we give to people. So a number of years ago, Adrienne Schneer, who was the first author on this paper, she was my PhD student at the time, and we looked at guidelines that were on the CMA website in 2012, 2013. And out of these 28 guidelines, there were 350 authors, and each of the authors had a conflict statement on the guideline There were 400 conflict statements. The F stands for financial conflict of interest. So some of the authors participated in more than one guideline. Almost half of the financial conflict of interest statements declared a conflict with a drug company, and 1/4 of the conflict statements applied to a conflict related to a company that was making a drug that was recommended in the guidelines. And overall, out of these 28 guidelines, about almost a third of them, over half of the doctors on the guideline committees had a financial relationship with companies making a recommended drug. Now, that doesn't mean that the recommendations in the guidelines are going to be biased. You can't tell that from this. All you can say is that these people had a financial conflict of interest with drug companies. But there is some evidence that it does bias what people have to say, or at least it biases how they interpret the evidence and the recommendations. And that comes out of the practice guidelines, or the clinical practice guidelines from the American Psychiatric Association about treating people who have major depressive disorder. These are patients, outpatients, not hospitalized patients. So out of the guideline membership, every person on the guideline committee had financial ties to the industry with a mean of 20 relationships per member. Almost half of the studies that were cited in the guidelines to support the recommendations were not of high methodologic quality. A third of the cited studies didn't actually study outpatients, which is the group that the guidelines were supposed to be referring to. 17% of the cited papers didn't measure clinically relevant results, and in 1/5 of the case, the studies that were cited did not actually support the recommendations that were being made. So at least in this one case, there is clearly an association. Now again, we can't go to cause and effect, but there's a strong association between financial conflict of interest and a relatively poor quality of the guidelines. And when we look at CME, here in Canada, this is CME that is accredited by the College of Family Physicians. 11% of the revenue from the Family Medicine Forum, this is the major conference, yearly conference that the college sponsors, 11% of the revenue comes from industry. Now the college is going to eliminate this by the end of 2024, and I'm highly supportive of that. A small amount of revenue, CME revenue that the national office of the college and the chapters get also comes from the industry. Again, this is in 2018. Again, this is supposed to go down, but there are unknown amounts of CME money from industry that are paid to medical education companies that sponsor CME events, and there's also an unknown amount of money that's given to university CME offices for their events. So although the college is getting rid of CME sponsorship by drug companies, there's still money going in to CME. We don't know how much, though. Although the college is going to eliminate CME funding by industry, there wasn't much support for from the people who attended the Family Medicine Forum for increasing CME membership fees by $50 to eliminate that funding. You can see here, this is a poll of 2,700 respondents, a pretty small number of actual attendees, but the majority of people were either very opposed or somewhat opposed to paying that extra $50 to get rid of the industry funding. So that indicates that the average, at least amongst these respondents, the average person is still not convinced that industry funding of CME is necessarily a bad thing. In terms of Canadian medical societies, we looked, again, Adrienne Chenier, part of her PhD, we looked at the policies of 60 different Canadian medical societies. There were a total of 236 policies that we found amongst these 60 organizations. We developed a scoring system, 21 different items around how well or poorly the policies addressed conflict of interest. So there was a maximum score that you could get of 63 if you had a perfect policy, at least as far as we were concerned. And no society got more than half of the maximum score, and 27, so almost half of them had their policies did not address any of these 21 items around CME, so they got scores of 0. So, last question. If drug companies didn't subsidize CME, I wouldn't go at all because it would be too expensive. I would go to fewer events. I'd pay the extra and still go. I'd only go to local events to avoid travel and accommodation costs. Well, remember that the companies, if you're looking at the Family Medicine Forum, the companies are not paying for the lectures. They're renting space in these to set up their booths. So what can we do about this relationship? So the first thing is that it is actually possible to do CME without industry money. Back in 2008, the Oregon chapter of the Academy of Family Physicians decided to no longer accept any money from drug companies at its educational seminars or at its conferences. And as far as I know, they're still holding their meetings. For the past 6 years, the Ontario chapter of the College of Family Physicians doesn't accept industry money at its annual scientific assembly. At the University of Alberta, the Division of Continuing Medical Education reduced its reliance on pharmaceutical money, and the Associate Dean of CME there said that they have much greater control over the content and the way in which things are delivered. And as I said a couple of minutes ago, the College of Family Physicians is moving in this direction. So stop seeing sales reps. Kaiser Permanente, which is on the U.S. West Coast, has 3.4 million members, employs 7,000 doctors, and it prohibits doctors from interacting with sales reps while they're at work. And according to the report that I read about this, 2 doctors left the group because of that policy. In smaller places, and this is in Australia, in Brisbane, the staff at one general practice clinic prohibited doctors from seeing sales reps during office hours, and 9 months later, they found that doctors were pretty happy with this policy and had reduced a lot of the time that they were spending with sales reps. Independent medical information. So what we need, in my opinion, is more academic detailing. For those of you who aren't familiar with it, this is where people are employed, typically these are clinical pharmacists, to go around to talk to doctors about prescribing issues. Sometimes they want to encourage doctors to prescribe more of something, so for hypertension. Sometimes they want to talk to them about switching the way they're prescribing. But these programs only exist currently in 3 provinces in Canada. Australia does something which I'm quite supportive of. They have what's called NPS Medicine Wise. This is run by independently, although they get their money from the government. They get $50 million a year from the Australian government to run educational programs for doctors. It's governed by an independent board. In 2015, they provided services to 24,000 GPs. So they do academic detailing. They do audit and feedback of doctors. Doctors can voluntarily agree that this organization can look at their prescribing behavior, measure it against prescribing behavior of doctors in the same area, and send them back results. And they run CME programs like the TI does. When it comes to guidelines, it makes a difference whether or not the who is sponsoring the guidelines. If it's government or non-profit organizations, so government would be things like the Canadian Task Force on Preventive Health. Nonprofits would be organizations that are set up. So if the Consumers Association of Canada sponsored a guidelines from government or nonprofits are much less likely to have panel members with a conflict of interest than are guidelines that are sponsored by either medical specialty societies or professional associations. So the Sunshine Act, I mentioned this in the US, and there actually was legislation passed in Ontario to set up a Sunshine Act in this province, and it was going to actually be wider than the one in the US because it was going to cover a wider range of organizations. So it wasn't going to be just doctors. It was going to be any regulated healthcare professional. It was going to cover hospitals, patient groups, medical organizations. But before the regulations to implement this were passed, we had an election. We elected Doug Ford as the premier, and all this got put on hold. There was a similar initiative discussed briefly in BC in the summer of 2018, but that didn't go anywhere. And although this would be a very positive step in terms of transparency, we have to remember that transparency is necessary but not sufficient. So, and there have been some studies that have looked at this. So one of them shows that once people have disclosed their conflicts, they then feel that the audience has been warned that they could be biased, and the speakers feel more at liberty to lie. And on the other hand, the audience that they're speaking to sees it in the reverse. They see, well, Lexchin told me about his conflicts, so he must be a pretty honest guy, so I think I can believe what he has to say. So we need more than just transparency, but transparency would be a good starting point. So, bottom line, from my point of view, don't see sales reps. Don't take samples. Don't go to talks given by key opinion leaders who are paid by drug companies. Use clinical practice guidelines that were produced by either nonprofit bodies or government panels. Go to CME that doesn't take money from drug companies. Push for a BC Sunshine Act and don't stop there. Don't think that you can't be influenced. And although I didn't put it in, support the TI. They're good people. So thank you for listening. And you can buy my book and make me rich. There's a blatant commercial plug.
Thanks a lot, Joel. I hope everyone can hear me now. I've managed to collect most of the questions that have been posed, and there's lots of them. So we'll try to scroll through these fairly quickly. One person asked right at the beginning about talking about the financial relationship, and asked basically, does attending drug dinners or accepting free samples, does that imply a financial relationship with the drug companies?
Typically, what's financial relationships are termed either money or what are called transfers of value. So the equivalent of money. So yeah, a meal from a drug company is certainly a transfer of value, and I would think that that taking samples is the same thing, although taking samples doesn't directly affect doctors, but it affects what they do.
Right. And so someone asked, what should people like Brian Goldman do if they've, quote, made mistakes in the past? I mean, do they pay it back somehow? Maybe curious to hear your suggestions.
Well, I mean, Brian has paid it back by admitting that he did it and saying he was wrong to do it, he's been public about this. So, yeah, I think that when people have done things that they think weren't appropriate, that admitting that voluntarily, not where some reporter does a gotcha on you, but admitting it voluntarily, I think has a strong effect. Are you there, Alan?
Yeah, I'm still here.
Oh,
so,
okay.
Just another, thanks for that. So someone also asked about participation in advisory boards and saying that this is common in my area. And the conflict seems obvious to me. What do you have to say about that?
I think the conflict is pretty obvious. Again, you're doing this. You're getting money back. You're a gift, and I think it creates a relationship. Often these being on advisory boards, the drug companies don't care what you think primarily. What they care is establishing this relationship with you so that you will repay that in some way. So maybe you will go on, speak about one of their products. Maybe you'll help them get something listed on a formulary. Maybe you'll just talk to your colleagues when you're having lunch about what you're doing for the drug company, and they seem like pretty good people. They're always friendly. They don't try and tell you what to do. They sit and they listen. So yeah, the drug companies, let's remember that the drug companies are run by really smart people. And they wouldn't be putting all this money into their relationships with doctors if they didn't think that they were getting more back from the money that they're spending.
Yes. So someone also asked about just the presence of small gifts, saying that small gifts can be problematic. So, but occasionally we have large organizations that allow their staff to accept small gifts. Do you have any suggestions for the employees of these organizations that technically allow the acceptance of small gifts?
So this can be very difficult to deal with. You certainly don't want to antagonize your colleagues. These are the people, if you're in a hospital, these are the people you're working with from day to day. You don't want them to get pissed off at you. They're nice people. They're trying to do what's best. And I think that what you need to do is you can lead by example. So you can go to, if the drug company is sponsoring a CME talk that you think would be useful to go to, you could go to that, and you don't eat any of the food that they give you. You don't drink any of the wine that they provide. You may take a glass of water. You listen to the talk, and then you leave. You can do that kind of thing. You can you don't have to be nasty to sales reps, but on the other hand, you can say hello to them and just walk by. So I think that leading by example and working with colleagues who think like you to gradually try and change the policy is something that is possible. We did that in the emergency group where I work. Drug companies used to pay. We used to run monthly CME events. We chose the speakers. The drug companies would pay the speakers' fees and pay for the meals. And over the years, the number of people in our group in favor of doing that kept going down and down and down. And when we had a vote, the vote was to stop getting the drug companies to sponsor those dinners. So now we have them in McDonald's.
So here's a question that flips things on its head. Do you know if pharma companies themselves allow healthcare workers to give gifts, pay for lunch or coffee with sales reps?
No, I don't. I would be very surprised if they did.
Yeah.
But I don't have any direct evidence.
Mm-hmm. Mm-hmm. So one question from one of our academic detailers, do you know how drug reps may have, activities might have changed during the pandemic?
Well, I would guess that there are many fewer visits since people are, a lot of doctors, at least in Ontario, are seeing people virtually. Family doctors are seeing people virtually. So drug companies, the sales reps wouldn't be able to visit their offices. Now, I don't know if they're setting up Zoom meetings with them or not. It's possible, but I don't know. And the other thing is drug companies are also gradually moving away from sales reps and incorporating other forms of promotion so that they're using social media to promote their products. I think that there's a larger focus on clinical practice guidelines, sponsoring those. So sales reps are still the single most important part of the promotion because it's that personal relationship that sets things up. If you're sales reps who've got a personal relationship with a doctor don't even have to mention the product. The doctors know which company they work for. The sales rep goes in, they talk about their golf game or their kids or something, and the sales rep says, "Nice to see you." The doctor says, "Nice to see you." And that's really all that's needed.
One of our participants asked about the guidelines that you were talking about, and have you included guidelines sponsored by disease-specific, not-for-profits, and so where would they land?
Those would, it depends whether or not the disease group has a relationship with the drug company, I would think. We didn't look at that specifically, and I don't know that anybody has actually studied that, but certainly in Canada, if people know about the Common Drug Review and the Pan-Canadian Oncology Drug Review, these are evaluations of new drugs, and they make recommendations to the provinces about whether or not to fund the particular product, or to fund it with conditions, or not to fund it at all. And I looked at the submissions from patient groups that had sponsorships or had accepted money from the drug companies, because in order for the patient groups to make the submission, they have to declare if they've got a conflict with companies. Mm-hmm. And about 90% of the time that these groups made a submission, it was in favor of funding the drug. So this doesn't, again, say that the relationship influenced what the patient groups were saying, but it's certainly, again, a pretty strong association between accepting money and saying and putting out a position that's in favor of what the drug companies want.
Mm-hmm. One of our participants asked about how can you detect if information is unbiased? I mean, if you yourself are not the expert, how can you even trust the guidelines anymore?
Okay, so, I mean, what I do, and emergency, we really prescribe a pretty narrow range of products. But generally what I do is I go to what I consider to be unbiased sources. So I will go to the TI. Is that what I was supposed to say, Alan? I go to the TI. I will go to Cochrane. And even if you can't get the full Cochrane review, the abstracts are free. You can see if Cochrane has said something about this. Go to the medical letter. There are a number of independent drug bulletins that are out there. The other thing to remember is that when it comes to at least family physicians typically use about 150 different drugs. That'll cover 90% of all the prescriptions that they write. There may be a couple of new drugs a year that come onto the market that will be useful for their practices. But 150 drugs is still a pretty narrow range, and you can read up over time on those 150 and become pretty comfortable using those, know when they shouldn't be used, when they should be used, what their safety issues might be. So I think that the combination of limiting your, at least if you're a family physician, limiting your range of drugs, and then when you have gaps in your knowledge, going to the independent sources will serve you pretty well.
So speaking of independent resources, one person asked us about, beyond the clinical practice guidelines, a large majority of docs are using things like point-of-care resources like UpToDate, and where the authors have more reign in the content, and those resources have a lot of reach. Is there any evidence of the financial conflicts of interest of authors in these resources?
Well, I don't know about UpToDate. I mean, a lot of my colleagues, people that I respect, use UpToDate and feel that it's a pretty good source. Cochrane will allow people with conflicts to be part of the group that writes the systematic review, but they have to be in a minority, and the chairs or the person who is heading the review can't have conflicts. So I think that that Cochrane is pretty reliable.
So you
and
remember,
I assume that the TI is also pretty reliable.
Thank you. We like to think so. Do you have any insights into the Sunshine Law in BC? And I know that's a question that you should probably be asking me, but do you have any outside opinion from your perspective in Ontario?
I think that it just fell, it was too low on the priority for the NDP a couple of years ago to go forward on it. But I'm really don't know for sure that that's the case. I mean, you know, I got called by or emailed by somebody. We had a conversation on the phone about this, and then they seemed interested at the time, but then they just dropped it.
Yeah.
And
yeah, so
be a good thing to lobby for.
Yeah, so on that front, what do you think the best way is to push government on this? Because the argument that they might be hearing is that, you know, the Faculty of Medicine at UBC and possibly official doctors' organizations are telling the government that if they bring in a Sunshine Law, it's going to lower the quality of medical education.
Well, I think that governments don't necessarily respond to experts. Experts have a role, but I think that one of the governments do respond to a bottom-up movement. So I think that one of the strategies for doctors is to encourage the people that they know, not their patients. I mean, I don't think doctors feel comfortable pushing political or controversial issues with their patients, but I think with their friends, talk about this kind of thing, and try and build up, if you do talks, you can talk to other doctors about it. If you talk to groups in the public about issues, you can bring this kind of thing up and generate some interest amongst the public in having having the government move on this issue. If you know reporters who might be interested in writing a story about this, talk to them about it, but push from the bottom.
Right, right. So another comment that in the U.S., states and federal government and private entities have pursued pharmaceutical companies in court, sometimes very successfully, for breaking FDA rules about marketing and on unapproved indications. Do you know if this has ever been achieved in Canada?
Never. For some reason, the Canadian government, both the federal government and the provincial governments, seem to think that unethical behavior by the drug companies stops at the 49th parallel. Not up here, you know, the same way as we don't have racism in Canada. It's in the United States, but once you cross the border, you're pure.
So we had a couple comments about the quality of diabetes guidelines in Canada, and we're almost at the end of our question time here. So maybe this might be the last question, but one person commented that in many ways the guidelines and the diabetes educators exam is based on the Diabetes Canada's guidelines, which myself and my colleagues and others have very many massive problems with the quality of these guidelines, particularly the huge conflicts of interest of the authors. And this person asked, is this a Goliath that can be tackled?
I don't know. I mean, diabetes diabetes is one of those areas where I would think that the drug companies are putting a lot of money, because there are a whole bunch of drugs. These are things that you're going to have to use typically for the rest of your life. And it's going to be a big uphill battle. I mean, the Canadian Diabetes Association is a powerful organization, and it'll be difficult to change their point of view. Is it impossible? Probably not. But again, this is not something that's going to happen overnight, and that's a pretty wishy-washy answer, but I'm afraid that it's about the best I can give.
Yes. Lots more questions and comments I can't really get to, Aaron. Do I need to be tying things up fairly soon, I think?
Yes, Alan, and just remind people about the evaluations.
Yes. So
Thank you.
There's an evaluation form that we're going to be, that will allow you to get credit for this event, and participants can receive that.
Only credit if they buy my book, Alan.
We will not be pushing Dr. Lexchin's book. I think it's available in any library. Just a last comment, a number of people mentioned a bunch of really good quality drug information sources. In BC, we have our provincial academic detailing program. There's a Prescrire, which is completely independent from the drug industry. There's RX Files, which is a group in Saskatchewan.
That's right.
And there's us, and there's a few others. So we kind of stick together. The Therapeutics Initiative belongs to a group called the International Society of Drug Bulletins, and that's a group of about 70-odd groups like the TI around the world that produce independent drug information. I wanted to see if Tom Perry can pop in here and say a few words right at the end. Tom?
Oh, thank you very much, Alan. I'm sorry, I'll turn on a better light. You can see me. Yeah, I want to thank Joel. I asked to do this because when I was a medical student at McGill University in Montreal in the 1970s, Joel was probably about a year ahead of me. And I think he was already known at that time for his interest in the topics he covered tonight. And it was a rather dangerous thing to do as a medical student in those days, just as Dr. Nav Persaud, now a distinguished professor of family medicine in Toronto, was quite courageous in taking on Purdue's relationship with the University of Toronto. So we're really pleased that you could do this, Joel, and I think it's a recognition of your international reputation that it looks to me from digging around on the internet in the background that there are people from as far away as Uruguay and possibly Venezuela, at least someone who knows about Venezuela, and the United Kingdom, and maybe further afield than that. So not everybody at this time of night can draw in an audience in those places, and I'd like to thank you very much on behalf of the
New Zealand.
And thank
somebody
you to
from
the audience too.
Okay, well, this was lots of fun.